All right, welcome to Delta webinar series today. My name is Honoriabe Uvo, and today we have a very important guest all the way from the west coast of the United States, Dr. Adam Mileski. Dr. Mileski went to University of Michigan. Go Blue! I left there in 2008. That happened to be the school that I did my post residency. Great, great institution. When he left there, he did complete AGD in general dentistry at Baylor College of Dentistry in Dallas in 2009, and then earned a mastership in Academy of General Dentistry in 2021. I'm just going to segue here, Doctor. How did that go? How did you? That's a lot of work trying to get a mastership in general dentistry. I'm sure you will talk about it as you go along. And he also board certified member of the American Board of General Dentistry in 2025. Dr. Mileski, you are welcome to Dental Webinar Series. Please take it away.
Yes, thank you very much for that warm introduction. And yes, I've been at it. It's a long process to do any of those things. Primarily, now I'm with Aspen Dental, working with 7 different offices and about 10 doctors, training them and helping them with implants. So I've given this talk to those doctors, and I think it'd be helpful to just kind of open it up to, what are some things, you'd want to learn or hear about into the implant career.
I have gone over to many schools in the west coast of Africa, many dental schools, and many, so why we started this series, many people have never, many of the dental students up to the time I went there, had never really touched or seen an implant being placed. They had watched videos of it. It's pretty elementary in terms of case selection, patient selection, and just being able to say, okay, what is too complex for me to try, or if this shouldn't be what I should be doing. How do I, place an implant safely, and how to restore. Most people are really concerned about that.
Well, that sounds great. This is pretty much what this is designed to do, is to give a very beginning introduction to implants for anybody who's thinking about introducing that into their career. So thank you. My apologies on the lateness from around the world. Fortunately, it's being recorded so people can watch it at their leisure. So,
Dr. Chide, do you have any particular interest? I know you have been you really want to place and restore implants.
Okay, thank you, Dr. Uvo, for that. I'm still at the early stages of, first of all, understanding the placements, and then before I can start thinking of restoration. So I think my interest right now is first of all, grasping the placements.
Okay.
Yes, and patient selection as well.
All
Though
right,
we've
good.
been discussing that in our meetings. So I think I have some good understanding of the patient selection now. So my main concern is the placements, implant selection, and all that.
Anyway, we have Dr. Mileski here, so I know that he will do justice to it. Okay, go ahead, sir.
okay. See if I can get these. Oh, there we go. So when it comes to implant dentistry, what I find is most students coming out of dental school, it's one of the most fear-inducing practices. Typically the schools are not willing to give them much exposure to it, and it's kind of a mystery. But what we found is that if the doctors really take a really good approach to the learning curve, they can actually learn it much faster than many other procedures. So when you really think about it, dental implants is a dental alveolar surgery which heals very predictably. And most of the risks and complications we can, either prevent or manage. The nice thing about working in the oral environment is, it's very forgiving, especially towards any bacteria that might already be in the mouth. And we know this from a long history of doing full mouth extractions, delivery of immediate dentures, and in any other manner of surgeries, that the healing can be very predictable. You mentioned case selection. Doing a thorough health history will help you kind of understand maybe some factors that might impair the healing, but there's not a lot of health conditions that we're finding that absolutely prevent implant placement. There's a few, but mostly we can work with health conditions that patients have. The soft tissue is very forgiving in the oral cavity. It granulates even if you cannot get primary closure. Healing is generally without scar formation, which for our profession, I think, is really a blessing. We are able to do things that you could not do on other parts of the body. And as far as damage that we might cause, is actually what the doctors are most afraid of is not based in reality. And as you start to understand, what a sinus floor is, what a Nidarian membrane is, and what it can do when punctured, and also the size of the nerve in the eye canal versus what you're seeing on the X-ray. Even when we get close to these structures, it's still very forgiving. So it's something that I think you can really take on, especially if you're getting in the habit of doing, more traditional dental surgery. Sometimes the dental implant can be even less traumatic than, a full mouth extraction with dentures, especially on cases where you don't have to lay much of a flap to place an implant. These are very minimally invasive. So if you're going to introduce dental implants into your practice, there are some prerequisites that you want to start mastering first. And the very first one is going to be epithelial dissection with raising flaps. So when it comes to placing implants, there's a restorative space requirement different than, say, a crown of a tooth. And accessing the bone to deal with things like fenestrations or grafting, we're going to have to get the gingival flap out of the way. So being able to raise a flap past the mucogingival junction, past the apex of the tooth, so that you can access that full buccal wall to work with it. And this is a skill that, you're going to end up practicing in your kind of traditional dental practice, things like surgical extractions. If you're not in a habit of raising a flap to remove buccal bone to extract a tooth, that's a good opportunity to start practicing and mastering that flap. Now, when it comes to bone removal, this is a important aspect of implant dentistry because one of the main reasons an implant is not going to function for you is lack of restorative space. The materials that we have minimums, and so being able to remove bone enough to get to that restorative space. And this is especially important in things of implant prosthetics. If you're doing locator implant overdentures, or you're doing, screw retained fixed hybrid attachments like all-on-4, it's absolutely critical that you're measuring and removing bone to the correct restorative space. Surgical isolation and visualization, definitely key. They say, see well what you do, and you'll do well what you see. this is where it all comes together, raising flaps, doing the bone reduction so that you can really see and understand the shape of the socket, any remaining root that might be left. One of the challenges doctors have is they're very afraid to remove any bone, um, believing that that would cause a case to fail. And in many ways, it's quite the opposite. You have to, work from the end result backwards. And removing bone early can be less damaging than, say, breaking the tooth over and over again, and then, having to dig it out. So when it comes to dental implants, this is really a tactical skill, meaning it's going to be improved by repetition. The didactic part of it is not going to get you all the way there. It's a very much understanding the bone by working with it. That's where you're really going to see how the density changes, from the lingual portion of the bone to the facial. It lets you kind of understand how soft bone reacts differently than dense bone. And all these things are just going to come from repetition. So I encourage doctors when they start their implant career is to really, be doing these every single week so that they're getting this muscle memory. The other one is if you're going to be a doctor placing implants, implants that don't integrate are going to be part of the career. So I try to encourage the doctors early on to start thinking about how are you going to react the first time that the implant does not integrate, and being emotionally prepared for that, because there is not a 100% success rate. And even in the literature, when they would say, very high numbers like 96%, it's not going to translate to every scenario. There are scenarios where it's impossible to have an implant integrate, no matter how perfectly you do it. And many of your cases will fall somewhere in between. The bone, I say to the doctor, is you do half the job. You put the implant in, but the body has to integrate with it. And you could do everything right, and the body can not integrate that implant. And so being prepared for that and having a strategy early on will make your learning curve much better. When it comes to your implant career, fear should not be the main dictator of your treatment planning. Really, you want to be treatment planning based upon the measurement requirements you need for, amount of bone surrounding your implant, the amount of restorative space, and when you're starting your career, not every case is going to be ideal, and that's okay. If you wait until you've done 100 ideal cases, you'll never do any implants. There's going to be a mix of things that you're consider slam dunks and things that you are afraid of. But, as you get comfortable with the process, the drills, the, placing the implant, getting insertion torque, it's okay to start taking some more challenging cases. And it's also okay to attempt to put an implant and, switch gears and graft it. Sometimes that's an important skill, is being able to, change up that plan midway, because what you thought you were going to get, you didn't get as far as like primary stability, things like that. And of course, implants not integrating should not be, how you're measuring your capabilities as a clinician. You're going to learn a lot more from the cases that don't go well than actually you learn from the cases that do. And if you have too many perfect cases, that can build complacency, where maybe, you get a little overconfident. So, I find that the learning curve is a lot of excitement, a lot of energy up front, and that gets followed by kind of a sense of despair. Like things start not working, you don't completely understand why, but then as you really start learning, then it becomes routine. And cases that, you'll start off thinking like, wow, I never thought I could do that, could potentially be something you do every day in your career. So if you're thinking about cases that you want to get started with, um, immediate 2 implant lower overdentures at the time of full mouth extraction is an extremely rewarding service for your patients. When I first started doing dentures with Aspen Dental, we did not have any implants for our patients. And so when a patient was getting a full lower denture, we would run out of options. We would reline it, we would remake it, we would do it over and over again, and it was just a lot of frustration. But when we gave this option where a patient could have even 2 locators, it completely changed the experience. And now, even though not every patient chose to go that route, we were able to satisfy patients that we never were able to satisfy before. And the whole process was just really motivating for the whole team. They really loved to be able to offer a new service and, to learn the new process of putting housings in a denture and doing that. So this is something you can definitely master, because by the time you're doing it, you're already doing surgery. You're already laying flaps. You're already understanding, that area of the mouth. From there, 2 implant low overdenture on an already edentulous patient actually can be a little bit more challenging because you don't have the same reference points to measure everything, but can be mastered. Immediate anterior and premolar implant crowns are a fantastic service for your patient. Let's say they break an upper first premolar, and you can take that out and at the same time put an implant. That patient, within 6 months can have that tooth again that is just like a tooth. They brush it, they floss it, they don't think about it. And now with some technology, such as scanners like Trios or iTero, the workflow is very easy. Down from that, anterior premolar implants in edentulous areas. These are the ones that patients or doctors really love to start with. When you have a tooth on either side of the edentulous area, it's very easy to find the dead center, and you can do that. And, like we were saying earlier, grafting a molar site and going in 6 months later is a very good workflow. It allows you to, not have to navigate the challenge of those 2 root sockets. And so starting off, that's kind of how we encourage the doctors to practice. After you've been, getting into a good routine, then you can start the more challenging ones, which would be like a maxillary 4-implant overdenture, or maybe adding more implants on the lower, like 3 or 4, and getting into molar immediate implant placement. One of the parts of dentistry that we've really embraced is the zirconia full arch replacement on 4 implants, the all on 4 protocol. This has been a lot more successful than even the 4-implant overdentures for the maxilla. And the end result is really giving patients something that's extremely natural appearing, highly functional, easy to maintain, and it's really satisfying the patients more than we ever have with overdentures. So as you become comfortable with implants, this may be something that you can introduce into your communities. One advantage of the all-on-4 zirconia fixed full arch is that the maintenance is very minimal. It's something a patient can brush in their mouth with a toothbrush and does not necessarily need to be removed for maintenance. And the zirconia being a lot more strong than acrylic can last a lot longer. So, in my part of the country, in the West Coast here, this is just taking off. There are many practices that are offering it, but it's definitely not the majority. And by bringing this into the communities, I feel very encouraged that we're doing something good for our communities. So for you to think about your path to success, get through a good didactic portion of implants. And there's many great implant series. Academy of General Dentistry has a lot of on-demand CE that you can have. I really like the California Implant Institute with Dr. Louis Al-Faraji. This is an instructor who I've personally taken his courses. He has an online fellowship program that I took that you can get a really well-rounded didactic education. ITI is another implant organization that does a lot of great CE. Actually, Aspen Dental's didactic is really modeled off of ITI. There's just so many. The Digital Dentistry Institute is another one that I've worked with in the past. Really great online and in-person CE. So, do what you can to find it. One other that I've taken is Implant Direct Passport program out of Las Vegas, where you can, they basically offer CE every single month. So, these are not organizations I'm affiliated with, but these are just courses that I've taken that I see the value in. And then placing implants every single week, I think, is more possible now. Back when we started doing it almost 10 years ago, the patients were not necessarily as ready, willing, and able. But now, with what we see, is it's very feasible to do implants every single week. So when you set up your standard of care, when you start to incorporate implants into your practice, you really want to start, setting what is the best for the patient and treatment planning that way, rather than trying to find the easiest case for you to do right away. So as we talked about, you're going to have patients that are going to go into dentures. Can you get your team ready to start doing 2 implants for a lower overdenture? You can get everything organized and ready. That's an option you can offer to every one of your edentulated patients. If you make your standard of care that, for single tooth edentulate sites, you're going to do an implant. If a patient breaks a premolar, offer them that service. And that's how you're going to really get your acceptance, is because you're treatment planning what's best for the patient, not necessarily what, you want to do right off of the bat. You really want to get in the practice of discussing implants at the patient's level. We don't need to give all the Greek and Latin and the technical terms and everything. Sometimes it's much better for a patient to understand, what's the final result that I'm looking for? What's the process. What's going to be my recovery? Is this something that we get put to sleep for? Is this something that's done under local anesthesia? And by the way, we do all of our work under local anesthesia. We do not do any general anesthesia. So letting the patient know the experience is way more important than the technical ins and outs of everything. And if you just present what's best for the patient can say yes or no. It doesn't have to affect you. But if you just give everybody the chance to do what's best for them, then there's going to be enough people that are going to say yes, that you're going to have an opportunity to grow your career like that. So when you get into your treatment planning, you want a good documentation. You want to be putting in any dental codes for insurance purposes. And then, like at Aspen, we have some checklists that kind of give us the codes so that we can, be able to not have to look them up in a book. They're just kind of ready to go. So you can see some examples like that. So having said that, I would just offer up any questions that come to mind about, getting ready to start your implant career or anything that we just covered up to now.
Talked about offering two implants. So what's the standard for the mandible? I noticed for the maxilla you said four implants over denture.
Correct.
You also mentioned three. So what's the where do you place those implants? What sites and what's your workflow when you're doing like a three implant over denture?
Yes. So, overdentures kind of started to mimic the canine overdenture, where they would, do a root canal in the canines, put a post with a locator on it. And so that was kind of how it started. And that's how the first implant overdentures came about. Instead of using the canine roots, we were putting implants into those sockets. Now we've learned that we can get more stability and more retention if we put 3 or 4 implants in on the lower. And then it's the best bone is going to be in between the mental foramina. So for example, in a 3 implant overdenture, you would put an implant in the first premolar sockets and then another one in the midline. When it comes to a 4 implant overdenture, what I typically do is angle the implants exactly like an all-on-4 protocol so that I can have my locator in the second premolar area and then 2 implants in between the canine areas. That's how we typically design those cases.
Okay, that's fine. Cool.
So when it comes to treatment planning for predictability, this is where, restraint in implant dentistry is going to come a long way. You really want to look at the patient as a whole, not just looking at an individual edentulous site. And patients that have advanced dental disease is going to be multifactorial. You're going to have patients with decay, periodontal disease, partial edentulism, and hypererupted, ectopic, and tilted teeth. So if we only think about implants as like a tooth crown replacement, that can become very dangerous. Because if you just fill every single edentulous spot with an implant, the other teeth may not survive. That disease can continue to progress. So understanding when you're using implants as a artificial tooth root versus when you're using implant as a skeletal anchoring device. And it's the difference between a restorative dentistry approach and a surgical prosthetic approach. And each has its own calling, a place to be. What I'd caution is to not only learn, restorative implant dentistry and apply them at every case. Um, you know, Understanding surgical prosthetics is going to be a big part of your implant career, on top of restorative dentistry. So a case like this, as you can see, this patient has multifactorial disease, and on the maxillary arch, to ensure the long-term prognosis of those teeth and doing prosthetic implant crowns in the back, very likely the patient is going to end up losing the teeth and having only those implants. So you should really be understanding the prognosis of your patient's current disease and practicing restraint. It's been a long established practice of disease control, not rushing into filling an edentulous site permanently, starting it off with, some type of acrylic partial, something to give time so that you can determine exactly, can you get this patient back to oral health before you get into a corrective phase where you're replacing teeth permanently. So implants will definitely change your paradigm. Teeth that you normally would have done what we call herodontics, you will not do that anymore. We very rarely put posts into teeth anymore. What we find is those teeth that are poorly restorable, such as premolars or anteriors, it's much more predictable to replace them with an implant than to do an endo, post, core, crown, and then the lifespan's a lot better. Dental bridges, is an interesting thing because in the beginning they look fantastic, but there's forces that happen on a tooth and a bridge that really reduce the lifespan, and that's well documented in the literature that 3-unit bridges are not going to have the same longevity as a single crown. We've really reduced to almost eliminating cast partial dentures because what we're finding is patients are really making the choice to either go to a surgical prosthetic route or doing what it takes to fill their edentulous areas with implant crowns, and they're not looking at a cast partial for their permanent tooth replacement, which is very good for the rest of the teeth because although cast partial dentures have a long history of success, they do not provide posterior support, especially in bilateral distal extensions. And we know about combination case syndrome, where over time teeth continue to hyper-erupt even when they're wearing a partial denture. So in many ways, we're having a better result out of implant overdentures than we are out of cast partial dentures. So bringing implants into your career lets you really treatment plan for the best standard of care for your patients. And they're not really upgrades or alternatives because, once you've discovered the best way to treat a dental problem, we don't have to go back into history of how things used to be. We can focus in on the things that work. So, this was an example of a patient that came in and she had these 2 implant crowns and wanted to get the rest of her mouth taken care of. And what really struck me was that she has some very successful dental implant crowns, but the rest of her teeth have continued to deteriorate. There has been no stopping to her periodontal disease, to her decay and recurrent decay, her partial edentulosum. None of that has resolved at all. And she really is working towards losing the teeth except for those implants. And so when you get a case coming in and a patient's got, a missing number 7, number 9, and all these other things going on, you want to be thinking about how are we getting their whole mouth to a solution, not just filling the few edentulous sites. Implants have different purposes, and how we place them are very different for when we're using them for like an all-on-4, an overdenture, an implant crown. So it's not a good practice to put an implant for a crown and say, oh, well, if they lose more teeth, we'll just turn it into an all-on-4. That's not a good practice. You really want to find a healthy solution for your patients. And so that's by giving them a comprehensive exam from the beginning. If we don't really look at the whole story, we can find answers that just don't go anywhere. If you look at the central incisor right side here, there appears to be an abscess, radiolucency at the tip of the root. And if we're accustomed to referring things to an endodontist to do an apicoectomy, an endo-retreat, something like that, we can deal with one small problem. But if we take a look at the same patient from another perspective, you can see that that abscess is not the only problem. This patient has an occlusal problem. They have a restorative problem, an aesthetic problem with the crown. They have a periodontal problem. And an endodontic solution is not going to really bring this person to oral health. And possibly an implant solution could get them a lot farther, because we could address the contour of the crown. We could address the infection. We could do things. So what we encourage our doctors to do is always a comprehensive exam, not really just limited exams. Look at the patient's oral health as a whole and find an answer that's not just solving the immediate thing. If you can act early, you can give your patient a lot more predictability. One thing that doctors out of school struggle with is, at what point is a prosthetic solution better than a restorative solution? And when we show this image to the doctors, many, said, well, we'll start with a cast partial denture, which is a good starting point for a discussion, because then we can start asking important questions like, what teeth are we going to use as abutments? And what needs to be done for these abutments? How strong are these abutments? What are the inherent limitations of a bilateral distal extension cast partial? What's going to happen if this person loses more teeth within the next 5 years? And when you start to put all these things together, you start to see, that cast partial denture doesn't sound very good for that patient, because it sounds like something very temporary that isn't really going to meet their challenges. And then we start to say, well, let's look at it from a different perspective. If these teeth have been diseased, they've been treated, they're continually having this disease, What if we looked at a prosthetic solution instead? And then we say, what's the result from an overdenture? What's the result from a fixed full arch? What's going to be the maintenance? What's going to be the function the patient's going to have? And when you start weighing it out, you start to see that, the patient's overall experience has been dramatically improved by the prosthetic approach rather than trying to just save every tooth and do a distal extension partial. So this is how implant dentistry really going to change your paradigm, because you're really patient-centered. You're trying to give patient options that are very predictable. And so a case like this, for a 2-implant overdenture, immediate placement of implants, now these surgeries are less than an hour. They're done under local anesthesia. The patient goes home with conventional dentures, and then 6 months later, we can put a locator abutments, and a patient can have a locator overdenture. So these are really rewarding things that you can integrate into your career. So that's kind of the introduction to it. I know we're at the 45-minute point. I'd say, do we want to keep going, or is this a good stopping point?
Do you have any like some cases just to show some planning that you did? And guys, if you guys have any questions, please do ask. But I would just hope it.
Yes, I do have some things like that.
Okay. Yeah, if you just show that, I think then that would help us to wrap it up. Yeah.
Okay. So here's an example here of surgery for a 2-implant overdenture. And so what I want you to see from it is the flap is being laid on both the facial and the lingual of the bone. And this is allowing us to access it to actually do bone reduction. As you can see, this ridge has been flattened, and this was from a pre-measurement. So before we extract the teeth, we measure the restorative space we want from the incisal edge, and then we score the bone so we know that we have the correct restorative space. From there, we can place the implants directly into the sockets, and then bone graft can be placed in, and then the flaps can be closed with the primary closure. So when you think about the amount of time you're already spending on a lower arch extraction and placement of a denture, this not only is almost as fast, the result is a lot better for healing. When we smooth the bone and remove any loose bone, the patients do not get bone spurs like they do when we don't lay a flap. We can completely see and make a very clean result. This is going to give your patient a lot less trouble for their healing as it goes there.
Okay, so when you are placing, so you did same day extraction, right? So you just
That's
took
correct.
out. So how do you, if are you drilling through the same, extraction socket that you took a tooth from, or you're going to where there's bone? And how much do you drill beyond the apex of the original tooth?
Correct. So yes, typically you're going into the socket for a lower overdenture, and the lateral incisor is a very good place. It leaves enough room if you ever want to add 2 more for a patient in the premolar region. And as far as the length of your implant, Carl Misch did research on this, and your implant should be between 12 and 15 millimeters long whenever possible. What he found was at less than 12 millimeters long, there was an increase of complications. But more than 15 millimeters long did not improve it anymore. So typically when we're sizing our implants, whenever possible, we find somewhere between 12 and 15 millimeters long.
Okay. Nice, nice. Good.
For an overdenture, this is never an issue. The times that we're using shorter implants are going to be usually molar sockets that we're going to end up picking a shorter implant.
Okay. So you talked about bone reduction. Can you go over that? I know you did mention that you have to kind of guesstimate how much the restorative parts will be. So how do you decide how much bone to reduce?
Correct. So when you have raised your facial flap, you can take your probe from the incisal edge of the tooth before it's extracted, and then you can score that on the bone, and it will leave a line of the exact amount of restorative space you need. So, in my opinion, if you're doing surgical prosthetics, meaning implant overdentures or full arch fixed, you should be between 15 and 17 millimeters for restorative space. If you're doing an implant crown, you want to be 3 millimeters below the adjacent CEJ to give 3 millimeters for the development of the emergence.
Okay.
So that's how we determine it.
Okay, nice. Okay.
And then a little bit on socket preservation. You mentioned grafting a site after it's extracted, a very worthwhile process. That can definitely be done. So when you extract a tooth, you can place an allograft as kind of the best. But if you want to do synthetic bone, that's going to work well also. Covering that with either a resorbable membrane, or in this case, a Teflon non-resorbable membrane. And then as you can see after healing, this membrane can be removed with just an Explorer. And that will granulate in and heal and develop a good bone volume for when you want to go in and do that as well.
Good.
Let's see if I had any other samples for. Let me show a little bit with treatment planning off of cone beam. So cone beam is really the standard that we've been working with. We can plan our cases from the beginning. If you do not have cone beam, then laying the flap and evaluating the bone and measuring it yourself with calipers is going to be the way to go. But, take for example here, the socket is typically not dead center in the bone. So when we're determining our implant placement, we don't want to simply go into the socket, but we want to engage the bone palatal to that socket. And so as you can see this implant being planned, the majority of it is into bone, and we're giving 4 millimeters of depth beyond the CEJ so that we can develop that emergence profile for when it's restored.
Okay, good. So do you typically use any angled abutments in case you're not able to get the angulation that is desired?
Yes, most labs now have gone to screw retained crowns with the
Hmm.
angled screw channel options. So we typically are not doing cement retained implant crowns. Those are only going to be when the lab cannot do an angled screw channel. Most of our cases are screw retained crowns.
Okay. All right. Thank you so much. This is really eye-opening. I'm going to give everybody an opportunity to speak. If you want to ask a question, Dr. Oshineye, if you have a question, Dr. Sam Karim, and Chinedu, Dr. Chinedu Ogu. Do you have any questions? And Dr. Chide.
Okay, I have a question, please.
Okay.
Yes,
Thank you so much, Doctor, for the beautiful presentation. And
my pleasure.
you really count my fears because I've been wondering and been should I say afraid of placing implants because of fear of failure,
Right.
fear of the implants not integrating and all that. But like you rightly said, we learn from the failures. So I saw an X-ray or one of the slides you showed. I saw you mentioned placing the implants in the socket of the lateral incisor, but then from the radiograph, it looked as if the implants were in the central incisor. Please, could you clarify that for me?
Yes.
Yes, this.
So, oh, let me go back. This window is covering up my screen from Zoom. Okay. Yeah. So, um, in the X-ray here, the bigger sockets are going to be where the canines were,
Very nice. Yeah, yeah,
and
yeah.
then
Okay.
the lateral is where the implants are. Um, if you put them
Okay.
both into the central, there's there. If you have less than 3 millimeters between implants, you can lose bone in between them. So
Okay.
we try to have, and this is a case where you would probably have about 10 millimeters from center of one implant to the center of the other. Um, so that's better for healing there.
Okay. Okay. Thank you.
If you're only gonna if you put them in the canine location, that's also a very good result. The only challenge is if the patient wants to add two more, you're not really able to angle the ones into the premolar zone. They would have to be straight. But you can still use shorter implants um, and make it work.
So if you place them in the canine position, would you still need to place the ones in the lateral incisor?
No, you would not. You would only put them in the canines, um, and then it would act the same with the two implant overdenture.
Okay. Thank you.
Yes.
All right. So if you had if you're going to place in a molar region, where would you place it? Around here? I mean, in the future, if you were deciding to add additional implants.
What you're going to find is if a patient has been edentulous in the molar area very long, these are not good sites for implants.
Hmm.
Uh, the way the bone resorbs is most of the buccal shelf comes off first, and it leaves all of your bone height just into the thinner lingual section of it. That's
I see.
why with the all on four protocol, by starting your implant in the second premolar socket and angling it 30 to 45 degrees forward, you can get as long of an implant as you want. Typically, we're doing 15 millimeter long implants, and you have all quality bone to put that in.
Okay. Awesome. Awesome. All right. Okay. Any other questions? All right. Thank you so much, Dr. Mileski. I know it's been, getting you to present to us has been very very rewarding, and just from the beginning, talking about all the things that you need to do. From flap, you need to be comfortable with doing some sort of surgery in terms of laying a flap, and being able to close it back, and all the pre things that you need to do, the planning, being able to restore, is quite insightful. Thank you so much. We really do appreciate your presentation today.
Well, I really appreciate the invitation, and I wish you the best of luck in your implant career, and hope to see you again next time.
All right. Thank you so much.